Hey Ubba-Bubba, welcome to JuanMD. My name is Juan, and today we are going to talk about another high-yield topic in pulmonology, pulmonary embolisms. Without further ado, let's get right to it. So pulmonary embolisms are when a blood clot from the lower extremities goes up into the heart and lodges itself into the pulmonary artery. Pulmonary embolisms usually come from the iliofemoral veins. They can originate more distally, but more common in the iliofemoral veins. These are more likely to happen in patients with congestive heart failure, predisposition to blood clotting, genetic predispositions. Does the patient have a factor V Leiden mutation? Does the patient have a protein C, protein S, an antithrombin 3 deficiency? Patients who have cancer, patients who are obese, have sedentary lifestyle? Did the patient just come from a really long airplane ride? This is super high yield, by the way. Patients with any metabolic syndrome? Does the patient have nephrotic syndrome? Patients who have a history of fracture or surgery, especially in the lower extremities, and patients who are pregnant. This usually presents as chest pain with a sharpness and radiating to the back. Patients will usually present with tachycardia. See, the pulmonary embolism is going to block blood from flowing from the right into the left heart chamber, and hence it's going to block blood from going into systemic circulation. Cardiac output is going to be low, and the heart is going to try to compensate by beating faster to send out more blood. Newsflash, doesn't work. You can also sometimes see hemoptysis and fainting in these patients. Physical exam would reveal a loud P2 and low breath sounds. Or sometimes you can even hear rales. You can have dyspnea, orthopnea, and you'll also note JVD because of blockage of blood flow from the superior vena cava. Infrequently, X-ray can reveal signs like Hampton hump, Westermarck sign, and patients are prone to severe sequelae like fainting, shock, and, well, death. And that's why you need to manage these conditions immediately. There are a lot of algorithms for determining how to manage these conditions, but before we go there, I want to sing a little song. I have a question. It might seem strange. How are your lungs? Are they in pain? Is there a sharpness inside your chest? I'd really like to know, if I may guess. Do you have a pulmonary embolism lodged inside your pulmonary artery? I'd like to know your dyspnea, it tells me so. Orthopnea, loud P, the tachycardia 2 and JVD. Can't you see the pH high and low CO2? The rales and low breath sounds suggest PE. Heart congested, or do you clot? Do you have cancer, dear? Oh, I hope not. You metabolic? Is it all the while? Did you break your leg? Are you bearing child? Do you have a pulmonary embolism lodged inside your artery? Westermarck side, your AA gradient is very high. The dyspnea, B2, the JVD and tachycardia 2. IVQ, please don't collapse, please don't be shocked, please don't cough blood, but gosh, you've got PE. A pulmonary embolism, spiral CT, do me a favor, get a D-dimer and quickly do me a favor, heparin if necessary. necessary. Do me a favor. Oh, do you have a pulmonary embolism lodged inside your pulmonary artery? I'd like to know your dyspnea. It tells me so, orthopnea, loud P, the tachycardia to a JVD. Can't you see your pH high, your low CO2? The rels and low breath sounds suggest PE. By the way, I really love the song that I based this parody on, so I'm gonna link that song above in the card. Go check it out. Awesome song. Gives me really happy feelings. So you've seen how your patient presents clinically. You've looked at the risk factors. Now you have to determine whether or not the patient has a high probability of having a pulmonary embolism. How do you do that? There's this thingy called the Wells criteria. There are several components. You have a score, and if the patient scores higher than 4, then they have a high probability of having PE. Less than or equal to 4, low pretest probability. First component, DVT or pulmonary embolism, is likely based on your clinical assessment. Give it the score of 3. Next, another diagnosis is unlikely. Give it another 3. If the patient presents with tachycardia, 1.5. The patient has either been immobilized for 3 days or has had a surgery within the past 4 days. Give it a 1.5. Then if the patient had a prior DVT or pulmonary embolism episode, give it another 1.5. Next up, the patient presents with hemoptysis. Give it a score of 1. Then the patient currently has cancer or any sort of malignancy. Give it another score of 1. You add that all together, the patient scores at least 4.5, then it's likely the patient has a pulmonary embolism. We're going to want to manage based on that. If the patient has a high likelihood of pulmonary embolism, you're going to want to do a spiral CT. If you can't do a spiral CT, then you'll do a VQ scan, or a ventilation perfusion scan. If either of those is contraindicated, then you will want to do leg ultrasound, or if the CT is inconclusive, you'll also want to do a leg ultrasound. Leg ultrasound is negative, you'll go and do a pulmonary angiogram if you suspect that the patient has a high risk of anticoagulation meds. Might as well do a pulmonary angiogram, right? However, if from the start the patient is already hemodynamically unstable, and you suspect you're going to do an embolectomy, then you're going to do a pulmonary angiogram as well. Now you have a low pretest probability. What do? You do a D-dimer test. A D-dimer test is done if you suspect a pulmonary embolism, and based on the Wells score, there is still a low pretest probability. Now, if the D-dimer is positive, then you'll go ahead and do a spiral CT anyway. Based on these tests, if the patient does have a likely pulmonary embolism, we're going to go ahead and do our management. At the start, we want to do airway, breathing, and circulation. We always start with that to make sure the patient is stable before doing any sort of intervention. So we start with airway. Always give supplemental oxygen. If the patient has severe hypoxemia or is at risk of respiratory failure, we're going to do an intubation. Is the patient hemodynamically stable? If the patient is not stable, we're going to do fluids. We're going to give pressors if necessary. We're going to refer the patient to a multidisciplinary team. Then we're going to admit the patient to the ICU. Next up, we're going to see if the patient is at high risk of pulmonary embolism and has low risk of bleeding. Then we are going to give anticoagulation meds. Which one we choose depends on the patient's stability. Now, is the patient unstable? If yes, we're going to give IV unfractionated heparin. Is the patient stable but has a low INR? Then we give warfarin and heparin together. Is the patient stable but unable to take oral medications? Then we give low molecular weight heparin. Then, can the patient take oral medications? Then finally, is the patient stable and able to take oral medications? If yes, we give direct oral anticoagulant, dabigatran. Next, we did the anticoags. Do we do thrombolysis? If the patient is unstable, has a high risk of pulmonary embolism, and has a low risk of bleeding, then we give thrombolysis. If the patient is stable but has an intermediate PE risk and has chances of right-sided heart failure, like indicated by an increased BNP and troponin level, then we also give thrombolysis. What drugs do thrombolysis? We have tissue plasminogen alteplase, or TPA, or streptokinase. Next intervention. The patient can't be given any of these meds. Do we do catheterized thrombolysis? What's the indication for this? If the patient has a high risk of fibrinolysis or has high risk of surgical intervention. Now, there is a thrombus, but it's huge. Then we will do a surgical thrombectomy. Is the patient at high bleeding risk and are any of these other interventions contraindicated? Then we will do IVC filter placement. We'll put the IVC filter there to prevent any rogue thrombus from going into the lungs. Now, once the patient is back to a lower bleeding risk, as soon as that happens, we can remove the IVC filter. Then we should do other interventions. And that, my friends, was pulmonary embolism in bite-sized pieces. That was all based on Step Up to Medicine 6th edition, written by Agabegi, published by Wolters-Kluwer. I'm not sponsored, by the way. I just think it's an awesome book. What do you think, guys? Did you guys like it? Did you not like it? If so, kindly click on that like button below. Also, click on subscribe and stay tuned for future videos. Click on that bell so that you can be notified when I do upload another video. Till next time, guys, take care of yourselves, eat healthy, don't smoke, do anything to prevent a pulmonary embolism. And this has been Juan. Always remember to live life to the fullest because you only have one life to live. Na 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 na.